Hello and welcome to our webinar Hemodynamic Assessment via TTE. In clinical practice, it's very important to evaluate the correct individual hemodynamic and volume status. For this purpose, TTE gains more and more importance, not only in intensive care units, even in perioperative setting. This webinar is not meant to give you a complete overview of TTE usage in terms of cardiac diagnostic or cardiac purposes, rather than give you a brief and practical algorithm to evaluate individual hemodynamic status. In order to understand hemodynamic assessment via TTE, it is important to know about basic principles of hemodynamics in postoperative care. Then I'm gonna explain TTE usage as an indicative tool, and particularly that you may perceive view diagnostics. Then we switch over to an advanced level of TTE, measuring cardiac output, and finally we merge this together in a rational hemodynamic algorithm with clinical decision making. Optimizing hemodynamics is very easy to understand. Our main target is the delivery of oxygen in tissues. While optimizing this, it's very important to know about the factors influencing DO2. Saturation depends from respiratory optimization, as well as HB, which can be assessed via transfusion, and cardiac output, which is influenced by stroke volume and heart rate. This is also dependent from volume, catecholamine, and or vascular tone. Improving these factors is very difficult. In particular, volume status is not very obvious and easily to access. Our primary goal is to achieve an unstressed volume status. Lack of volume may result in lesser tissue perfusion, which may lead to renal insufficiency, as well as stressed volume isn't beneficial in terms of intestinal perfusion. Thus, we have to establish unstressed volume, and this volume status varies very quickly, so it's very important to assess individual volume status at different times individually. In this regard, TTE usage is a beneficial tool, but is indispensable to interpret the indicative signs correctly. Using TTE as an indicative tool, it is very important to improve the so-called eyeballing qualities. Then you can easily evaluate in a B mode left and right ventricular contractility, cardiac diameters and dimension. For this purpose, it's very important to know about the normal diameters and dimensions. Then you can easily identify ventricular and atrial filling pathologies. In this regard, you have to focus on ventricular and atrial diameters towards each other. Then we continue to evaluate overall valves. In particular, we search for valvular pathologies, for example, stenosis, insufficiency, as well as endocarditic structures. And finally, if you're getting more and more experience in TTE, you will exhibit more and more interesting findings which are relevant to understand hemodynamics in each patient. In order to implement TTE skills, it is important to know about the basic TTE sectional planes. In clinical practice, we have three basic positions: parasternal, long axis, and short axis view, with the marker heading towards the right patient's shoulder. While turning the marker to the left patient's shoulder, you can access the short axis view. In this position, you can angle the probe and access other sectional planes. Then turn over to the apical sectional planes, 4 and 5 chamber view, while turning the marker of the probe to the left patient's shoulder. While turning the marker 90 degrees towards the right shoulder, you can access 2 chamber view. While turning 110 degrees, you can access the 3-chamber view. And finally, the subcostal views. With the marker heading the left shoulder, you can access 4-chamber view. By turning 90 degrees towards the right shoulder, you can access short axis view. And by swiping a little bit towards the left shoulder, you can access the inferior cavital vein. To establish a correct interpretation of the image sequences, it is necessary to follow basic TTE principles. For example, if you intend to make a point on a left ventricular function, it is necessary that you use more than one sectional plane to evaluate this special problem. You can pick this in a parasternal view as well as an apical view or in a subcostal view. But remember, you always have to use the sequence B mode first and then C mode to evaluate possible valve pathologies. If you have the suspicion on valvular pathologies, you may use CV for quantifying if applicable. For inexperienced users, it's sometimes hard to differ CV and PV, but it's quite simple. Use CV for quantifying valve pathologies and pulse wave Doppler for hemodynamic assessment of stroke volume or relaxant disorders. In the presentation of the respective structures in each sectional plane, it is important to know about the presented structures. First, we start with the parasternal long axis view. The marker is turning to the left patient shoulder. Here you see good contractility with normal cavities. The left ventricle is very obvious. In the center, right ventricular left atrium, aortic valve, and the anteromitral leaflet and the posterior mitral leaflet. Turning the probe 90 degrees towards the patient's left shoulder, you can easily access the parasternal short axis view. You can see the right ventricle and the left ventricle with the papillary muscles. By swiping towards the patient's right shoulder, you can see the anterior and posterior mitral leaflet. Swiping back towards the apex, you can access right ventricular, tricuspidal valve, pulmonary valve, interatrial septum, left atrium, and the aortic valve, with the respective right coronary cusp, left coronary cusp, and acoronary cusp. Always remember, the right coronary cusp is the nearest towards the sternum. In the apical position, the marker is heading towards the patient's left shoulder. Then you can see the left ventricle, the right ventricle, right atrium, left atrium, and the tricuspidal and mitral valve. By lowering the probe at this position, you can access the 5-chamber view, with the aortic valve in the middle and the left ventricular output tract LVOT beyond. Placing the pulse wave marker in the LVOT, you can measure velocity time integral for hemodynamic assessment. The correct interpretation of cardiac preload is an important eyeballing skill. For this purpose, you have to focus on diastolic wall movement and filling, and the systolic and diastolic cross-sectional area of each cavity, which has to be set in relation to each other. It's important to know about the normal diameters of each cavity to identify possible pathologic findings. In order to get complete information about cardiac preload, it is important to use C mode to identify possible valvular pathologies, which may have an impact on hemodynamics and may alter clinical decision-making. But always remember, ideally you have to display at least 2 sectional planes to make a statement. The long axis view findings have to be confirmed for example in the short axis view parasternal. Again, you have to focus on the systolic and diastolic cross-sectional diameters. In particular, you have to search for end-diastolic persistence of myocardial wall movement. In the four-chamber view, you have to follow the same algorithm. You have to evaluate shortening and thickening and cross-sectional diameters. Additionally, you have to keep an eye on the correct dimensions, in particular left and right ventricular dimension. Evaluate systolic and diastolic filling, and by using a C mode you can identify possible jets. If a jet is present, you can quantify this jet by using continuous wave Doppler. By following this simple process, you will have a steep learning curve. Subsequently, you will soon be able to assess even complex hemodynamic findings. In this case, for example, we can find an impaired ventricular arterial ratio with regurgitation beyond the tricuspidal mitral valve, with preserved ventricular function possibly caused by arrhythmia, for example, atrial fibrillation. Applying the C mode after the B mode evaluation, you can possibly identify jets. In this case, we see a jet in the tricuspidal valve position, which may yield information for pulmonary hypertension. And finally, by using the continuous wave Doppler aligning with the jet, you can easily quantify the severity of pulmonary arterial hypertension. Besides volume status, contractility is the other important point in order to understand hemodynamics. Therefore, you have to evaluate both qualities of contractility, the shortening and thickening of the myocard. In this sectional plane, you additionally have to keep an eye on systolic mitral annulus movement. These findings have to be verified in a second sectional plane, for example, the short axis view parasternal. You have to focus on systolic and diastolic cross-sectional diameters, as well as myocardial thickening. In the four-chamber view, you can assess right and left ventricular contractility. For this purpose, for right ventricular contractility, you can use the TAPSE, the tricuspidal annulus systolic elevation, which can be easily assessed via an M mode, and the systolic elevation of the mitral annulus, which can be used as a surrogate for shortening of the left ventricle myocard. And finally, overall thickening of the myocard has to be inspected. Besides these basic skills, it is important to improve overall view diagnostics. For this purpose, it is important to know about certain pathologies. At first, you have to identify normal findings. Then you get a level up to identify high volume status. In this example, you may possibly identify the end-diastolic freeze of the myocard indicating high volume level. Using the C mode, it is important to know about turbulence and laminar flows. If a valvular stenosis insufficiency are present, you will see more yellow and green parts indicating turbulence flow. Building on the previous explanations, you may easily assess the following findings. But always remember, don't be frustrated if you are not able to get sufficient image quality in every sectional plane, which may impede overall decision making. If you're getting more and more experience, you can also assess difficult findings while image quality is worse. And finally, do not be terrified in using the sectional probe. You can only improve your skills by using this device. and you may alter patient's outcome. Additionally, you can find even raw findings, for example, pulmonary embolism, and it's very impressive to see this in real time. Even more, you will be able to assess a more different hemodynamic status, for example, a difference in right and left ventricular function. To get a complete overview of left and right ventricular function, it is important to know about basic and advanced measurements, and you have to put this in a clear and rational algorithm. For right ventricular assessment, we begin with a B mode. You have to have a look on dimensions, for example in the parasternal long axis view as well in the four-chamber view. Then step over to evaluate right ventricular and left ventricular ratio, as well as the right ventricular and right atrial ratio, for example in the four-chamber view. Keep an eye on abnormal wall movement, indicating, for example, a septal shift, which indicates right heart stress. You can quantify a right ventricular function by using the TAPSE. Then you can search for valvular disorders using B mode first, then color mode. And if a jet is present, you can measure it and quantifying by using continuous wave Doppler. The left ventricular assessment algorithm is quite similar. First, you have to use B mode, where you can evaluate dimensions, then keep an eye on ratios, abnormal wall movement, and then switch over to evaluate valvular disorders with first B mode, then color mode, if a jet is present in mitral valve position, or for example in the five-chamber view in the aortic valve position. You can quantify this jet by using continuous wave Doppler. In contrast to the right ventricular assessment, within the left ventricular assessment, velocity time integral measurement in the LVOT is essential in order to evaluate left ventricular function. VTI measurement is essential for cardiac output calculation. In order to understand stroke volume and the respective measurement, it is important to imagine that within every stroke, one bottle is spread through the aortic valve. All we have to do is measure volume of a bottle. For this purpose, you have to calculate bottom, multiply it with height, then you get the stroke volume. Bottom is quite easy to access, R square, multiplied with P, and the height is very easy to calculate, it's the velocity time integral. Then you get stroke volume. Multiplied with heart rate, you get cardiac output. For VTI measurement in LVOT, you have to install the four-chamber view, then lowering the probe, then you get the five-chamber view. Align the pulse wave Doppler with the aortic bloodstream. A maximum angle error of 20 degrees is allowed. Then you get the pulse signal. You can circle this signal and you get the velocity time integral, which is essential for cardiac output measurement. Now it is time to put all displayed instruments of hemodynamic assessment into a rational algorithm. In our daily clinical routine, we have to deal with several pathologic conditions, which are not easy to assess, and decision-making is time-sensitive. To provide timely therapy, which may reduce the need for hospitalization and improve the patient's outcome, it is important to follow a simple algorithm. First, look at your patient, as well as clinical signs. Then, take into account B parameters, the laboratory parameters. Then use TTE evaluation with the known routine B mode first, then C mode. If valvular pathologies are present, try to quantify them using continuous wave Doppler. And finally, use the pulse wave Doppler in order to quantify velocity time integral. To illustrate the meaning of the TTE, I would like to give you some examples that the finding does not have the same cause. In this regard, the VTI measurement is an important finding for an exact differentiation. VTI depends on the preload as well as the contractility. The normal value is about 20 centimeters. If this value is lowered and the contractility is normal, then a response to volume can be assumed. It should be noted that the filling of the cavities evaluated in B mode and the size ratios must be related to possible valve pathologies. Thereafter, an interpretation of the measured VTI can be made. In the overall interpretation, however, an algorithm should always be adhered to, and the VTI measurement should only be interpreted in the context of the findings. However, one should always keep in mind that there are also sources of error in the measurements and eyeballing qualities. Nevertheless, after a short settling time, the TTE will soon become a powerful tool in the decision making. In summary, TTE usage in perioperative care is an important tool to improve and optimize therapy, in particular decision making. I hope you enjoyed this webinar here. Join us again at sonosite.com. Thanks for watching and goodbye.